Well, hello, everyone. Good morning, good afternoon, good evening, depending upon where in the world you're coming from. We've got people registered from Morocco, China, Turkey, Germany, the UK, the United States, Canada. So it's a pretty broad group, and who knows what time it is. There's nothing I can't be accurate on that, but we're delighted you're here. Uh, um, uh, MedVR is a medical XR accelerator. We are a nonprofit and an educational organization in terms of our structure. Our goal is to increase the number of research and development and product development projects in the application of extended reality to medicine and healthcare. I won't elaborate too much. There's plenty on our website that you can learn quite a bit about us, and we're happy to meet with you at another time as well. I'd like to call everyone's attention to the fact that we have two chats here. We've got a regular chat, which is just for everyone to talk to one another. And we have another chat, a Q&A chat, if you look down at the bottom of your screen. If you've got a question, please put it in the chat. And at the end of the talk, we'll get to those questions, and I'll also be shepherding the regular chat to make sure that everybody uses the Q&A chat so that you have the best chance of getting your question answered. I am delighted to introduce our moderator, Dr. Veronica Vesser. She is Associate Director of XR Pediatrics, part of the Yale Center of Immersive Technologies in Pediatrics, and a research scientist at the Yale School of Medicine. She's part of an interdisciplinary team of research educators and healthcare professionals and video game designers who collaborate to develop and evaluate theory and evidence-formed video game health promotion interventions utilizing VR and spatial computing technology. I've known this center at Yale for probably four years. They do phenomenal things, so we really appreciate having her on board. And I'll turn it over to you, Veronica. Oh, you're muted.
Of course I am. You'd think we'd all be professionals at this fight at that point, but thank you so much for introducing me, Steve. I'm so happy to be here, and I'm so happy to be having this opportunity to moderate such an exciting panel. I am just so excited to hear all about how this team has come together to create what I think is a really incredible opportunity to learn about infection control and prevention using VR. And I'm just thrilled to hand it over to Dr. Erica Shenoy, who will introduce the rest of the team and launch the presentation. Thank you so much.
Thanks so much, Veronica. Thanks to everyone. It's pretty cool to see that we've got people calling in from all over the world. We're gonna get our slides up on the screen. And I will be talking about infection prevention and control, and I think it's international as terms of a topic. So hopefully those of you will see kind of threads here from maybe any clinical interactions you've had, but also we'll be focusing mostly on the technology that we've been using as part of this project. So our title is Getting Real Clean, Immersive, Interactive, and Gamified Training for Infection Control. I'm joined here by this awesome team that I will introduce in the next couple slides. As a disclosure, the work presented here is from a cooperative agreement we were so fortunate to have from the Centers for Disease Control and Prevention. And unfortunately, that funding has ceased, but we're so excited to show you all we've done over the past several years on this work. Next slide. So the team that will be part of the team that will be speaking with you today is myself. So just by way of background, I'm an adult infectious diseases physician. My main job is as Chief of Infection Control at Mass General Brigham, which is about 15 facilities. I'm so pleased to have Vianelli Garcia, who's one of our clinical research coordinators. Andrea Greenfield is an infection preventionist, works at the team at Mass General, and it was part of this project team. And then Michelle Jerry, our clinical research coordinator. Organizing the slides on the back here is our program manager, Chloe Green. Next slide. But actually, we have a huge team, and anybody who's done this work knows that you need lots of different expertise. I won't name all the names here, but there are many clinicians. There's adult education specialists. There are designers. There are VR developers. There are individuals who are specialized in analytics. So really a very large group with a diverse set of knowledge that we have been really fortunate to pull together for this project. Next slide. I want to make special thank yous. I always do these at the start because sometimes we're crammed at the end for thank yous. And thank you to Stephen, Isa, Jenny, and the MedVR community. Veronica, not only for being a moderator, but for giving us some really instrumental feedback as we've been iterating in our different versionings of our modules. Obviously, the CDC, without their support, this would not be possible. And we'll be showing a lot of data from our pilot sites around the United States. And their input was really instrumental in the versioning and making these products really better than what we possibly had hoped for in the beginning. And then obviously our project team here at Mass General and Mass General Brigham. Next slide. So here are the objectives. For those of you who are non-clinical, and even if you're clinical and don't know infection prevention and control, this is where I kind of try to explain the next couple slides why we chose to apply this technology to this sort of area. And what I'm really hoping you'll understand is why we think immersive virtual reality training is so important for what we consider foundational infection prevention and control. You'll hear me use the acronym IPC, education among healthcare personnel. These are the things that if we did right and did really well, kind of consistently, we would prevent so many infections among our patients and could really be transformative for healthcare. I'm going to show you what we've done to date in both designing and piloting our IPC training and talk about two specific modules, one related to portable medical equipment, that's stuff that gets moved around the hospital all the time. The other one is like foundational principles of infection prevention. And hopefully some of these will be familiar to you. And then really kind of show you some cool things we've been doing using the performance data from our headsets, understanding if people are actually learning as they do this, which, you know, that would be our end goal here. And then some of the things that we've learned as a team and some recommendations where we think the VR community could be really helpful in terms of advancing the field. Next slide. So whether you're in healthcare or you watch healthcare on TV, this might be a typical scene that would be shown maybe even in like a reality TV show of some sort. When you look at this, you might be kind of thinking, oh, what's going on in the scene? When I look at it and my team looks at it from an infection prevention perspective, I'm like seeing all the potential risks to our patients and to our staff from infections and the potential for transmission. As a very fine point here, I'm looking at this and I'm thinking, where is the hand sanitizer? We know that the hands of healthcare workers are like the #1 way that we transfer organisms from the contaminated environment from one patient to another. And I think they're all blocked by all the stretchers in the hallway. And yet this is the reality of where our healthcare workers are interacting with. Not every hallway looks like this, but healthcare is incredibly complex. There's a lot of equipment there. There's a lot going on. We're not even hearing the noises in the background and all the distractions that are kind of taking our healthcare personnel's attention away from those foundational things that we know are so important. So have that picture in your mind of the reality. We go to the next slide, you'll see what is this reality and how can we study it in a way that identifies all these risks that are out there. So this was a really neat study where they had individuals basically standing outside the door of different units in a hospital. So on the right, goes from top to bottom, mixed medical, medical intensive care, and surgical intensive care units. And all they were doing is really looking at the hands of healthcare workers and seeing what they were touching. In the middle of these diagrams, the biggest circle is the patient, and everything else that they're touching. And each of those gray lines is one of those touches. And what did they find? 3 of the top 10 sequences involve staff touching portable medical equipment and the patient, and there really wasn't much hand hygiene happening. And if a typical healthcare worker in the typical course of activities might need to clean their hands 100 times a shift, that's how many times there are opportunities from when you're going from something that's dirty to a clean task. And so that's just to conceive about how many times that has to happen and how many opportunities there are to fail. If you click forward, you'll see that they did this grid, and this is kind of horrific, potentially, if you're not in healthcare. But if you go on the left, you're looking, the first column are the different units. The bottom line are the average times that infection control practices were observed per encounter. And if you just read across, you'll see that hand sanitation occurred 1.2 times. I already told you in a shift, it's like 100 times. And disinfection, it's kind of sad that they even calculated the average because it's like 0.06. They're not cleaning that equipment. And nobody in healthcare goes to work each day saying, I'm going to do something that would potentially risk my patient and transfer pathogens from one person to the other or equipment. It's just the reality that you saw on that other screen is really overwhelming and makes it really hard for people to see the risk, appreciate the risk, and do what they need to do. Next slide. So the basics that I'm talking about in terms of foundational principles are hand hygiene. And some of you may be cringing and thinking, how is it possible that in 2025, people are not cleaning their hands? And it's actually very true that they're not cleaning their hands. And I'll show you in a moment how often they're not cleaning their hands. Cleaning and disinfection of portable medical equipment, incredibly important. And actually over time, the amount of portable medical equipment is increasing. And you really can't walk into any healthcare environment and not see many different devices that were going between patients. And lastly, personal protective equipment. We think of that as a way to protect the healthcare worker, but in using it and using it incorrectly, you can actually promote cross and self-contamination. And so some of the studies out there, if we click through on hand hygiene, report compliance around can be less than 10%, and in some of the studies, which are hard to believe, over 80%, but the average is 40%. That's a lot of missed opportunities. For cleaning and disinfection of portable medical equipment, many studies have looked at equipment, they swab them, they look for pathogenic bacteria, and shockingly, or not shockingly, they find it in the majority of equipment. And these have been linked to outbreaks in healthcare settings, some very high profile, New England Journal of Medicine, JAMA, other instances in which has actually been documented. And then for personal protective equipment, multiple outbreaks associated with failures to use PPE correctly, essentially using PPE in ways that actually promotes cross-contamination. Next slide. So why are we failing? I think one of the motivations for me getting into this area and thinking like, what is out there that could help us do this better is that I teach infection control all the time. I even help create the annual training for our entire system, but everything we're doing is not working because the literature shows us it's not working. Part of that is probably knowledge, but also belief in the effectiveness of IPC interventions. Like it's ingrained in my brain that my hands are a risk to others, and therefore like I believe it and I can kind of visualize in my brain the invisible pathogens, but that may be not something that most individuals are really thinking about. There's also this risk perception and recognition, which is you think about the risk to the patient. Often the risk to self tends to like override the way people are thinking and acting in healthcare. That's just a human sort of thing that happens, but also not really appreciating what's the risk to other patients. And then lastly, we're making trade-offs all the time. That's life, where there's time constraints, there's competing priorities, there's burnout. And so unless we make something truly muscle memory that is really resilient to all of those sorts of features, we are going to continue to fail on these basic interventions. Next slide. Now, this group is probably all in on VR. I'm guessing you're all in on VR. So you know that there's like a lot of potential here for VR to help us help clinicians and other healthcare personnel kind of understand, feel the emotion of the sorts of things that they're doing, maybe see the unseen, see the potential consequences of not doing hand hygiene, and then to physically practice those activities that we really want to ingrain in their brain so that they're not even having to think about it, they're just doing it. It also allows us to do trainings that are consistent and reproducible. Right now, you basically learn on the job, or you learn through your daily activity where you're not actually getting the reinforcement, either positive or negative, for what you're doing. And you're just kind of like out there, and you never see the consequence that I failed to wash my hands this time. I transferred an organism to this patient. They then ended up having infection. You're never really getting that feedback, and therefore you're not prompted to improve. Next slide. We have some great colleagues out there. The top two images here on the left are from our colleagues at Emory, who have been doing amazing work and sort of seeing the unseen and bringing that out to the forefront. The image at the bottom you'll recognize in a few minutes from some of our work, and then also giving like real-time feedback. What I was trying to say before is like, I may go into a room and I think I'm doing everything right. I'm there on my own. No one's there to kind of nudge me in the right direction. In VR, we can do that, and then we can assess how that nudge improves future performance. Next slide. With that, I'm going to turn it over to Andrea to kind of show you what we've come up with. Thanks.
All right, thank you, Erica. So I'm going to take you through our two training courses that we built out. The first one was Cleaning and Disinfecting Portable Medical Equipment, or PME, and this teaches the core aspects of cleaning and disinfection, and the learner gets to practice hands-on with a device of their choosing. In our second build, Infection Prevention Foundations, we take a step back a little bit and teach around broader infection prevention concepts, and the learner gets to seek out infection risks and perform a series of tasks on a healthcare unit. So we're going to see some key parts of each course, and then I'm going to show a demo of each. So our approach was to teach with realism. We started off our development process by thinking about the different infection prevention scenarios and tasks that we see healthcare personnel encounter every single day. And from there, we looked at where we see a lack of knowledge or understanding, where do we actually see mistakes in practice. Our approach was to build a course that allows learners to naturally encounter these tasks with an emphasis on education, repetition, and feedback. So with VR, the learner can see the healthcare setting that they're in all the time and view it in a different light. And we can use that along with real-time feedback, which, as we've heard, is really rare in practice, to teach and reinforce concepts. So our setting is again realistic, but a generic healthcare environment. Our trainings are meant to be applicable to a series of healthcare personnel across roles and who may work in various different settings. So we started off with that room and hall that you can see on the left-hand side, and we built on that gradually over time, adding a central workstation, a tutorial space, a clean supply room, and other patient rooms. So participants can move freely within this area and are able to handle most objects in a way that's similar to real life. And we also included a soundscape to help kind of lend to that realistic, kind of immersive nature of the experience. I'm thinking about recreating the real world versus representing the unseen. On the left, we have a close-up of one of our pieces of portable medical equipment. This is a point of care ultrasound. It's post-procedure, and you can see some gel on the holder, or excuse me, on the probe, which is on the left-hand side. That's the white aspect of the device. And then on the holder, which is the little black circular element. That holder is often missed, and this is something that we see out in practice all the time that gets that is forgotten in the cleaning. And so we wanted to include that as something to teach around. We also represent the unseen to drive home the why, again, behind that best practice. And so on the right-hand side, we have a representation of contamination. We can see those handprints and see how that contamination takes place over the just standard use of that item. Now, our learners are holding a pair of handheld controllers. We're using the MedQuest VR. And with this, one of the challenges is that they can't practice the actual mechanics of hand hygiene. What we can do instead is make sure that hand sanitizer and sinks are positioned in locations to promote best practice. For example, we have them at the doorways and in the patient rooms. And we can also make sure that they actuate the wood in real life, and we'll get to see that in the demo. Most importantly, though, we wanted to build out and include scenarios where we're expecting healthcare personnel to do hand hygiene. And when they make errors or miss that hand hygiene, we offer them real-time feedback. It's consistent, it pops up every time. And you're going to get to see this in action in the demo as well as on this right-hand panel. So gloves, similarly, you're not going to get to practice putting on and taking off gloves when you're holding a pair of controllers. So we position them in predictable locations and where we would expect and actually need the learner to use them for the task. And we emphasized important aspects such as that gloves don't replace hand hygiene. In terms of actual donning and doffing, putting those gloves on and off, the process of doing that is really, really important. And so we worked with our developer to use an animation to show best practice. And so we have a grab feature where the learner can interact and they can start that, and then an animation plays showing essentially like the appropriate hand position. Now, disinfection, being thorough, is really important, and we took a couple of different approaches to help reinforce this for our learners. So our first try was to use these game-like blocks, and so these essentially serve as targets, essentially encouraging the learner to go ahead and address all the different surfaces of that device. This is not going to be an option for them in real life, though, and so we switched to using essentially a painting feature. And so what happens as you're wiping the surface of that device is you see that subtle change in color and texture. This is really similar to what you happen to see in real life. What happens on the back end for us is that we can see how much or what percentage of that device has actually been wiped, and that helps us assess performance. And then we added a panel so that learners, as they're working, can get a sense of what percentage of that object they've actually wiped down. So with that intro, I am going to go ahead and show a demo. So our cleaning and disinfection module, when learners are in it, it takes them about 20 minutes to go through and practice. Our demo is going to be about 2 minutes. And this module is available in both English and Spanish. So starting off, our learner can watch a couple of videos, the first explaining the Spalding classification, which helps us decide how we want to disinfect items. And then they also get to choose their equipment. You can see that here. Now we're going to test our knowledge. And as we're working through our quiz, you can hear a little bit of that immersive soundscape. Now when we're done, we're going to retrieve our clean equipment from its designated area, and we're going to take that to a patient room. Here's our first example of a missed hand hygiene. And you're going to see us course correct. So you can hear that audio and the color of the hands change. And skipping ahead, we're done our procedure, and now we're seeing the unseen. We're getting to see those that contamination that happened, and also how that took place as we use the device. A contact time is really important with disinfection. That's how long the product needs to stay wet to actually be disinfected. So we're going to check that on our wipes. We're going to test our knowledge. And then we're going to make a selection of what cleaning product. And this is really important in real life. If we pick the wrong one based on the information in the module, we get a reminder. We're going to start by cleaning away the visible soil. You can see us wiping off the gel from the probe and then addressing the holder next. And now you get to see that painting feature in action. So you can see that change in the color and texture. And we get a cue if we've been using our wipe for a long time. Now there are some arrows on each of our cables to try to encourage us to wipe in the direction of from cleaner areas to dirtier areas. And you can see how we turn that device. Here is our glove doffing. You can see that animation of that best hand practice. And we always do hand hygiene after we take off our PPE. So we're going to clean our hands. We're going to take our cleaned equipment and return it to its designated space. And we get to see a little bit more about how we did. We have that encouraging music. So we learned a lot about building and testing with our first training module. And as I go through our IP foundations, you're going to see we took some different approaches. And actually, this is how we sat down and just tried to figure out how the learner was going to move through this space that we had created. So first up, we created an enhanced tutorial where learners could practice what we discovered through piloting, where the most common or challenging maneuvers. And thank you, Veronica, for your input on this aspect. We also added non-playable characters or NPCs to help guide our learners with less text. Shout out to our instructional designer, Chandra Cox, who suggested this and helped us develop these characters. She voiced one of them. Our center panel is Gertrude. We're going to meet her in the demo. She orients our learner to the setting and gives them some initial sort of rules of play. And then Tiffany later on helps contextualize a task that we're going to be performing and gives us a cue when we're doing something out of order. So in this module, our participant is going to search through the environment, scavenger hunt style, to identify common infection control risks. Now, these are things that we see all the time that honestly, as a healthcare worker, you kind of become blind to. It's really hard sometimes to actually perceive the things that you're seeing. And so they go through the unit, and as they find these risks and they click on them, they get a score that appears, and you can see that in that center panel. At the end, they get to see how they did cumulatively. They have the opportunity to learn a little bit more in about each of those risks, and they can go back and see what they may have missed. Now, in addition to just recreating common errors, again, we can use visuals to drive home the why. What's the significance of the thing that we found? So our coworker in gown and gloves that we saw before, we can see how the surfaces that they touched and how germs might spread through that clean space. Thinking about sinks, those of us in infection prevention know that they're a reservoir where pathogens can sort of proliferate. And so we get to see the splash zone. This is a contaminated area that essentially that contamination happens just over the standard use of that sink. And so we know that we don't want to store supplies or prepare medications in that area. PPE like hand hygiene, again, challenging to kind of replicate in the virtual world and animate that. And so we worked with our developers essentially to show the most important parts. And so we focus on reinforcing when to wear them. Things like making sure that the ties are secured at the neck and the waist. And you can see in that center panel, we have essentially a mirror view so that the learner can see what they look like and where the gown is on their body. And then we use some visual cues and some NPC reminders to help that learner make sure that they're working in sequence. So I'm going to go ahead and demo our foundations. This course runs about 20 minutes and it is available in English, but our demo will be about 2 minutes. So here we are, we're starting off in our tutorial space. Our learner can spend as much time here as they want, just kind of getting familiar with the interactions. When they're ready, they're going to go to the door, they're going to take their gloves off, they're going to do hand sanitizer, and then they're going to enter the space and meet Gertrude, our first character.
Hey there, welcome to the unit. My name is Gertrude. I am the receptionist here, so I have a good sense of everything going on. Oh my goodness, that specimen should not be sitting on the counter. That can spread germs around the space. Would you mind pointing and clicking on that vial to properly bag and remove it from the counter? Amazing! You just identified your first infection risk. Keep an eye out for other infection risks around the unit.
You're needed in
Click on
patient room
Hi
1.
Gertrude, how are you? Just bring in Mr. McConnell to room 1.
So as we're moving through the environment, we're looking for those risks. For example, we have an overfilled sharps container. We can see our score updating as we work. We have a basket of clean supplies on a sink that I was talking about. And so when we click on that, we kind of pull up that option to see the splash zone. In our clean supply, we have some equipment that is damaged. We have a coworker who's accessing clean supply with dirty gloves, and we can see the impact of that. And we also have a door propped open where it shouldn't be.
Remember to hold the soiled linens away from your body as you carry them.
And so our NPCs are offering some guidance. We see here again an opportunity for hand hygiene as we're between tasks. We're taking off our gloves and we miss. We have that immediate feedback again.
Oops, you're going out of order. Check the poster on the wall or the instruction panel for the correct order.
And so here we're putting on our PPE for a task that is going to create splashes and sprays. So we want to put on our gown, our gloves, our face mask, and eye protection, and we're going to work through that order. In a second, we're going to skip ahead to the doffing, and you're going to see in the mirror view how we animated that. So you can look in the center of the screen as that gown comes off. And now we're going to discard. And again, just kind of showing an animation of best practice in the scenario where everything's coming off in one step. And then this is skipping ahead to the end where we get to see our cumulative score, learn a little bit more about what might be there, get a hint about what we may want to go back and find. And so with that, I am going to hand it off to my colleagues, Michelle and Vianelli, who are going to take us through our work piloting.
Yeah, hi. Next slide, please. So to pilot our VR module, we've been following a quality improvement model. We started off piloting our PME module, which was the first demo you saw, at 3 sites, and gathered feedback and used that to revise our module and pilot again at phase 2, and also use that feedback to build our foundations module, which was the second demo you saw. So phase 3 was our largest pilot with 6 sites trying out version 3 of the PME module and version 2 of our foundations module. And as you can see from this map, we have piloted all over the country. Next, please. So we had 177 healthcare personnel try out our module, with a vast majority who have never tried VR before or who had only been in it once or twice. The majority of our users were in nursing and ranged from 19 to 65 years of age. So as I mentioned, we piloted our modules using a quality improvement approach, and our first round was focused on user experience. We collected our data using semi-structured interviews, followed by a thematic coding process to analyze the data, and this was done for both modules. In our subsequent pilots, we also looked at in-module performance through HMD collected analytics, which is like the back-end data of what the user is doing in the module. So for example, we can see when our participants miss hand hygiene or how many tasks they've completed, and we will be looking a little bit at what this entails later. Yeah, and lastly, we have our pre-post knowledge assessment, which we only have for our PME module, and I will walk through those results later as well. So now diving into our user experience results, some of our main takeaways for our VR training is how much people really enjoyed the game-like nature of it, especially the interactive and immersive elements. Participants also reported learning new things from the VR module or being refreshed on IPC topics. Most notably, almost all of our users preferred the VR module over traditional IPC training and would recommend our training to other professionals in similar roles as theirs. Yeah, next slide. But it wasn't all rainbows and unicorns. We also experienced what most others experience when piloting VR, which is issues with nausea, dizziness, blurriness, other negative physical sensations. So as Andrea touched on a little bit before we went to our next phase of the quality improvement module, we made some revisions to help mitigate these challenges. For example, we tried to simplify the mechanisms to perform tasks in VR. We created that VR tutorial to help people get familiar with those controllers. And we also had Gertrude present and other NPC characters, because this would reduce our need for text, lessening the burden of reading in VR, which can help mitigate some of that eye strain, headaches, and blurriness that people were experiencing. So all of these changes did result in improved VR navigation and reduced reports of negative physical sensations by our users. Yeah, next slide, please. So in our most recent pilots, previous one. Thank you. We created a REDCap survey to assess user experience in VR. We had 11 questions on a 5-point Likert scale in which participants could say if they strongly agreed to some of our statements, which was a 5, or strongly disagreed, which was a 1. And the first column is the mean Likert scale response for our foundations module, and the second column is the mean Likert scale responses for our PME module. And from the scores, we can see that people thought the graphics were clear and easy to read in this latest round of revisions. And similarly to the feedback we received in the interviews, users thought our module was more engaging than other infection control trainings and enhanced their interest in IPC in general. Users also reported that they would recommend it to teach IPC to other healthcare professionals as well. And from the columns, you can see that on the right, all of the values are above a 4. So between those two green smiley faces for our PME module, and so it was very well received. Our foundations module also had a majority of responses being a 4 or higher, but we did get some 3s. Our PME module has gone through 3 cycles of revisions, while our foundations module is only on its second iteration. So there is still some room for growth over there. But now I'm going to pass it to Vinelli to talk a little bit about that HMD analytics piece. Thank you.
Alrighty, so I'll be jumping on. This is Vianelli here. So as Michelle mentioned, thank you for those revisions and findings that you cover. So we're going to dive into the head-mounted display data, specifically looking at the cleaning and disinfection of PME. And on the next slide, I will walk you through a case study from one of our recent participants, one of our pilot sites. So as you can see here, this participant role is in nursing, and they had done VR once or twice before, and they chose the ultrasound machine as the portable medical equipment that they will clean and disinfect. And directly from the data, we get to see how they perform for disinfection, how often they perform hand hygiene, and as well as how they did on task and quizzes. So for their disinfection percentages, we can see that they obtain a 0% for the basket or the bin, and similarly for the gel bottles, so they did not disinfect those two parts of the machine. Then for the screen, they receive an 8% disinfection percentage and then a 44% for the body of the machine. And moving ahead, for the transducer, that probe and cable, they disinfected that at 92%. And lastly, for the transducer holder, they fully disinfected that at 100%. And overall, from all those parts of the machine that they did disinfect, they obtained an overall 41% disinfection score. So from this data, we can see how participants are doing in terms of disinfection overall, and which parts are often disinfected and which parts are often missed. And we can calculate this across participants and see if there's any trends in terms of is the Vitos machine more often clean and disinfected efficiently, or is the Focus machine, the point of care ultrasound, disinfected more often, and also which parts across the board. And moving ahead, we can also see the missed hand hygiene opportunity. So for this participant, we can see that they missed 4 instances of hand hygiene, 3 times when they're entering the patient room and 1 time when they were leaving the patient room at a later point. And we can see how often they miss hand hygiene and also at what points in the training. So as you can see, in this case, it's tied to whether they're entering or leaving the patient room. And we can see that across participants and start to notice trends as to whether participants are missing most often on entering or leaving. And if we look ahead on the next slide, as mentioned before, we can also see how they do in terms of quiz performance. So for this participant, in 8 out of the 9 quizzes throughout the module, they responded correctly on their first attempt. We get to see what kind of responses they put into each quiz and see how many attempts it takes them to get to the correct response. And we get this data for all our participants and can really identify areas where participants might need more reinforcement or education based on their quiz responses in the moment as they're in the training. And looking ahead too, we can see which tasks they completed throughout the training. So we know that this participant missed 3 tasks throughout the training. They did not watch one of the educational videos in the beginning of the module. They did not listen to an audio explanation of contact time, and they did not complete a quiz on identifying contact time for the disinfection product. And we can see at what point these tasks were missed and if there's any kind of pattern across participants as to whether certain tasks are often missed or often skipped by participants, and if that impacts their knowledge gain in the knowledge assessment, which Michelle will cover later on. And now we can shift over to our other module, or IPC Foundations module, and I'll cover again an example of the head-mounted display data we're getting for that particular module and how we analyze it. And from here on, again, we have a participant from our recent pilot site. This participant's role is in patient care, and they had no VR experience before trying this module. And from the data, we see that they found 9 out of the 16 infection risks in the environment. And we can see not only which ones they identified, but also which ones they did not identify. So as we click through, you can see that they did not identify the open wipes container, which amounted to 2 points. They did not identify the overfilled straps container in the patient room, and they had 2 opportunities to find that, and they did not. They did not find the colleague wearing gloves in the clean utility room, and they did not identify the colleague with an untied isolation gown in the patient room, as well as they did not identify the open linen cart in the clean utility room. So we can see for this particular participant that they might not recognize an overfilled straps container as an infection risk, and they might not have full understanding of correct PPE use. And across the board in participants, we can see which infection risks are often found, which ones are often missed, and if there's any kind of pattern across whether an infection risk is in the beginning of the training or if it's later on in the training as they become more overwhelmed with tasks that we missed them on. And then as before, we can see when missing hygiene is taking place. So we know for this participant, they missed 2 instances of hand hygiene when they were first leaving the patient room and then later on when they were leaving the patient room again. So for this participant, we can recognize that they might need more reinforcement of the importance of hand hygiene when leaving the patient room. And again, we can identify trends and patterns across all participants in this particular module as to when they're missing hand hygiene and how many times that takes place. And moving forward, we can see again how they do in terms of quizzes and tasks. This training module only has 1 quiz that refers to asking if they should use a supply in the supply room that has damaged packaging. And as expected, this participant responded correctly on this quiz on their first attempt, but we can see that across the board, whether participants tend to respond correctly and how many attempts it takes them. And for number of tasks and task completion, we can see that they did not complete 2 tasks during the training, and in this case it was they did not check in with a colleague and they did not complete the donning of personal protective equipment, so they unfortunately didn't have the opportunity to practice donning their PPE. And we can see again if there's any kind of pattern across what participants are not completing and if that ties into any kind of knowledge gain at the end after the training. And moving forward to overall what we think about head-mounted display data. So we really hope to have showcased how we apply and use this data in our modules and really reinforce that this data allows a great opportunity for assessment and retraining of individual participants that do these VR sessions and VR trainings. We also highlight how this can be used for performance trends and see how people are performing across the board, and truly to inform or design revisions. We want to make sure that we are designing the best possible trainings that we can and that participants are performing as well as possible based on the design. And overall, head-mounted display data provides real-time performance assessment and feedback insights from each VR training session across the board. And with that, I will pass it over to Michelle, who will take over my spot here.
Hi, everyone. I'm back. Next slide, please. So we had two sections in our evaluation material, and this is specifically for our PME module. The first was an IPC knowledge assessment that was taken by participants pre and post the VR training module. The second was an attitude and confidence survey that was also taken pre and post the VR training module. Next slide, please. So the knowledge assessment was a 10-question multiple choice questionnaire. The questions were designed to assess infection control learning objectives, with some questions adapted from CDC competency resources. And before the training, participants got an average of 7.54 out of 10, and post the VR training, the score increased to 8.19. So this was like a 0.65 point increase. And we did a paired t-test to assess statistical significance and found that the increase in scores was statistically significant with a p-value of 0.0012, and this showcases to us that the VR training can actually increase participant knowledge. Next, please. Our next assessment was the IPC Attitude and Confidence Survey. These were, again, 11 questions on a 5-point Likert scale, and we found that the change in mean Likert scale responses were statistically significant for all of 10 questions. Only one question did not have was not significant, and this was it's important to perform hand hygiene before entering or exiting a patient care area. And this is probably due to the ceiling effect, as the pre-survey responses to this question were already very high, and there's a lot of education on hand hygiene. Although I think it's interesting to note that while people did rate it as really important, when we looked at the headset data that Vianelli showed earlier, we saw that they were still missed hand hygiene opportunities as people were entering and exiting patient rooms. And the questions with the largest effect size were specifically on some teaching points that we had, which was the difference between critical, non-critical, and semi-critical equipment, and the correct order of steps to clean and disinfect PME. And so these results do overall show that participants' attitudes, confidence, and knowledge can increase through VR training. And I'll now pass it to Erica to talk a little bit about our lessons learned and what's next.
Great, thank you. And we'll get to those questions. Some of them already come in. So just a few lessons learned of what our team, this is like 3 years in the making, so bullets related to 3 years, but we really felt like the participants, and we've shown, widely accepted the VR module. They really liked the immersion interactions. They found those highly valuable. And this was really across age ranges. And even though some expressed initial trepidation, that was actually completely not an issue for the modules. We showed that what is in the literature in terms of observations of real life, we're also seeing that in the virtual world, where we really do see opportunities for improvement in hand hygiene and cleaning and disinfection, those kind of foundational infection prevention principles. And we did show, and I think this is really exciting, that there is an increase in IPC knowledge as well as attitudes and confidence. And that latter aspect, I think, is really powerful in terms of reinforcement of the knowledge and feeling confident that you have the knowledge and that knowledge is actually correct. On the opposite side, if people felt very confident about misinformation, that would be more of a problem for us. But this is really exciting. Next slide is just kind of thinking about the future. So what this actually, one of the questions in the chat I was seeing was asking about, like, how do we change the levels of difficulty? And that is a really exciting opportunity. I think it pairs well with a way to design teaching where if someone nails a topic and is really good at that, we can probably focus on other things and actually tailor the learning to them in a way that, like, think will be much more acceptable to people because they're actually focusing on the areas that they need to focus on and not on others. It can also give us some potentially direction on what is the kind of cadence where even basic stuff that they got the first time needs to be reinforced. And also as kind of knowledge progresses, could we actually tailor this again to the individual and have a cadence that reflects their knowledge? So if someone has a really hard time on one topic, maybe they need to go redo it again, and then maybe they need to see that again in 3 months versus a 6-month or annual basis. I think what we're really hoping for is that we are able to teach infection prevention better. That leads to better knowledge, skills, retention of that. That translates into the real world. And because it translates into the real world, we have fewer healthcare associated infections. So kind of coming full circle to why we would even kind of approach VR. And I think one anecdote that one of our team members mentioned is that someone in the pilot, that red banner that says you forgot hand hygiene or you missed something, they said that like they had that in their head when they went back to the unit. And so that's kind of really exciting that people are kind of like we're trying to translate reality into VR. Now they're taking VR back into their everyday life. And I think we're potentially onto something here. And while this project is closing, unfortunately, related to the funding, we're hopeful that in the future we can revisit this and really take this further and show the value of VR for this particular use case. And with that, I'll stop and we'll start with questions. We can take the slides down and get everyone on camera.
That was fantastic. Thank you so much for walking us through. It was just really wonderful to see both how you structured the talk around pointing out all these areas where IPC really needs improvement, and then taking us into how you created this VR module and showing your actual results, including the HMD data of what people were really doing. That was just fabulous. I'd love to ask, I'm so sorry to hear about the funding ending, but what do you see as the future for this program that you've created? Were you able to leave some headsets at any of the partner sites that you worked with? Did any of them express interest in continuing to use the training modules? Is there support for that going forward?
Yeah, so a couple ways to look at this. First of all, we've been publishing a lot, and we have a couple papers that are some that have been published, a couple more in the hopper. And so we're kind of putting out our findings through kind of the academic literature. While this particular funding stream has ended, we do still have access to the modules. We have our headsets. And even in our last pilots, there was a huge amount of interest. They wanted us to come back again. And so we're really looking kind of broadly across our own institution to see if there's ways to keep this going until we can find more funding and then bring it back. We've even been working with our innovations team to see if there's a way to bring this. I think I kind of describe this as, I don't think it's ready for prime time, in the sense that I don't think it can replace kind of existing, there's a whole regulatory framework around what healthcare workers need to learn. So I don't think it can replace that, but I think we're getting close to the point where maybe we can peel off components if we can actually show the knowledge gain and maybe make it as a kind of parallel track for staff who really want to do their annual training in a different way. I think we're close to that, but we don't have kind of the institutional or the kind of outside institutional resources to make that happen.
That makes sense. I'm going to jump to this question from Chen Cao, who asks relatedly, how scalable is this approach for hospitals and lower resource facilities, or how can the lessons learned be applied given the pause in funding?
That is a great question. Our one of the papers we're submitting is actually looking at the use in long-term care facilities. And maybe I can hop over to, I don't know, Michelle, do you want to talk about the long-term care facilities and some of the unique challenges? And I say long-term care because they're generally less resourced than acute care hospitals, even less resourced than an academic medical center. But a lot of excitement there, challenged by a particular set of things. Michelle?
Yeah, I think there was definitely a lot of interest in VR for IPC in those settings. I think we piloted with a couple of hospitals in the Midwest, and there was some like natural tornadoes or like the lack of Wi-Fi, the power would go out, and that made it really difficult to run the VR because it is Wi-Fi based. And so trying to tackle those issues, I think, would be a little bit of a barrier. but I think there was definitely interest to pilot through.
And just to speak on that point of scalability, thanks for raising that. I think this is like an eminently scalable sort of technology. Like the hard work around the kind of the content and the revisions and all that, that's done. If you wanted to replicate that sort of like really beautiful infection prevention sort of stuff with teachers across the country, you couldn't find enough people who could do that in a reliable and consistent way. And the headsets, you know, they are expensive, but the price point is coming down. So I think it's really eminently scalable. I think it requires an infrastructure of like a program and like a landing place where people can go and access it. And we just are not resourced to do that right now, unfortunately.
Yeah, that makes complete sense. And it sounds like you've been able to reduce a lot of the like the VR hesitancy and some of the VR negative experiences that some of your participants have used. So I'm sure that also speaks to your ability to scale this program if you had more resources. Do you think that as the program stands now, you would require your team to go in and support? Imagine you had infinite funding, infinite headsets. Do you think you could hand off these infinite headsets to another group and they would be able to get participants through without any issue? Or do you think there's still a bit of a use barrier in terms of wearing the headsets, finding the software, and getting through the program?
I'll say one thing and then I'll maybe ask Bianelli or Michelle their thoughts on this. I think our team did a really good job of trying to do a train the trainer sort of approach. There's like a toolkit and there's like a thing that like you can hand off to someone and they, I think for the most part could do it maybe with a call line or something else. But I think there's been so many iteration and work with our pilot sites that they found a way to make it almost like, I don't know, you know, when you like order, I've never done this, but I've seen the commercials for when you order a meal and all you have to do is open the box and follow the instructions. I feel like that is kind of where we are. Now, the downside is like we want the analytics, we want to like study it, we're academics, we want to like improve. And that part probably not possible at this point. But Michelle or Vianelli, thoughts on whether people could just open it up like one of those food things?
Yeah, I mean, we have a whole implementation guide with all the different Q&As, how to deal with headset fit, how to put it on when you have glasses, how to like help mitigate negative physical sensations, even how to like cast and set up. We have all of those resources, and our pilot sites were set up so that we would have like a 1 hour Zoom call, kind of walk them through how to use the VR, and then those pilot site managers across the countries would kind of practice on their own and then go recruit and train people in their institution. So far it was working well like that. So I do think that there's hope and ability to do that even further in the future.
Fantastic. The meal kit of VR infection prevention training. I love it. That's great. I'm going to pair up two other questions from the audience that we have. These are both related to how the user gets feedback throughout the experience. And I'm going to add to it one of my own questions. So we have from Muskan, were your users informed about what they missed after completing the module? And then were there scores that you collected all through the quizzes that we saw examples of in VR, or did you have any outside of VR surveys that you asked for people? And then I also wondered why you chose to have some of the in VR quizzes be skippable and how that impacts someone's score at the very end.
So maybe Vianelli, do you want to talk about how they can see what they're missing and then during it, and then at the very end, when you see that, you can see all the things that you got right and got wrong. You could still go back, right, and do it if you wanted to, correct?
Yes. Can you hear me now?
Yes, you're good.
Of course. Okay, perfect. So I can take part of that question in terms of the feedback and the information that the participant gets as they're doing the training. So as Erica was touching on, they can see how many infection risks they found towards the end. They can see the score on the screen as they go through, and then at the very end, they have the chance to see how many out of the 16 they have found so far, and then they can decide to submit the findings or keep looking. This is specifically for the infection risk. And once they submit their findings, that's final. They get to see that checklist of all the ones they did find and which ones they did not, and really get an explanation as to why these are considered infection risk and which ones they did not find. That now hopefully sticks with them for the future. And as far as the cleaning and disinfection, as they're cleaning and disinfecting the machine, specifically disinfection, they can see those percentages going up on that panel on the screen. So you can get that kind of feedback, and then you get your final score at the very end. And to the last part, in terms of the quizzes, we show them if they get the answer correctly, or if they put the wrong answer, we encourage them to keep trying until they get the correct answer. But unfortunately, there are some quizzes that if they just completely skip the step where the quiz lives, they can move past it without completing the quiz. And I'll pass it over to Michelle for some of the survey information that we did, in addition to the quizzes that happen inside the module.
Could you go through the question about the non-in-module surveys?
Oh, I'm so sorry. Yes, we were wondering, Lydia asked, are all of the surveys that you and data that you collected from users about their experience and about their knowledge gained from your training, are all of them collected in the headset through VR, or do you have like pen and paper or
Oh, yeah.
separate afterwards?
Perfect, thank you. So they were red cap surveys. So kind of how we structured it was we knew who was coming to either do their module in the respective pilot sites or in our own institutions. And so we would send those pre-surveys ahead of time with a red cap link, and they could fill that out, and then they'd come for the training and we'd give them the post survey on red cap again. So the ones that were in the headset were just kind of like the ones you saw in the tutorial.
Okay,
Yeah, thank
you. We have another question from Chen about, are there other technologies that you're interested in exploring or incorporating for future phases of this training module? For instance, AI or robotics?
Oh, wow. So exciting, tantalizing, all the things we could do. We were actually meeting with some informatics fellows yesterday, and the question came on of like augmented reality, like where they could take these and then go into their own clinical setting and see the infection risks. And there's just so much potential there. You know, I think in a different time, or maybe in the future, we could think about these really cool things. But Chen, you're always at the leading edge of things. So thank you for raising that.
Awesome. And I just wanted to say that we had a comment earlier about how fantastic your environments look and how immersive they all felt. I thought the sound was really, really spectacular in particular. But I did wonder, was there ever the concern that having so much detail and so much richness in your environment might actually make it pretty hard to do your scavenger hunt task and kind of distract people from the goal of finding these infection risks?
Interesting. Well, life is distracting. So I think, you know, the team did a really good job. There were times when we wanted to get super fancy, and then we kind of pulled ourselves back and try to use like the detail when it really matters. I think as Andrew was showing, like the looking at something that's wet when you're wiping it down, the kind of hand hygiene, the sounds, that audio track is actually made from people walking around our hospital and recording the ambient noise. So we think like in some ways that's probably part of it, is try to have those kind of distractions a little bit in the background, because that's real life. And if you can find them in that realm, maybe you'll be more attuned to them when you're up in the wards walking around. So I really appreciate this, like the opportunity for our team to be here and all the great feedback. And if you do see something that you think there's a way for us to continue, please reach out to us directly. We're going to try to keep little things alive in our publications and other ways to keep this work kind of, I don't know, and not cryogenically frozen, but, you know, like there, so that we can pick it up potentially in the future.
Amazing. Thank you so much. This is fantastic. I really appreciate the audience and all of your questions and the opportunity to hear this really wonderful talk. So I'll turn it back to Steve. Thank you.
Well, this is a wonderful talk. You know, it's an element that I think XR can repeat, which is teaching situational awareness through gamification. I thought this was a fantastic talk. It also reminded me, I was listening to a podcast with Neil deGrasse Tyson last week, and he said that in the when humans were living in caves, by the time that people were 30 years old, half their population had died. And then in 1840, half the population had died before reaching 35. So there was only 5 years in all this time. And since 1840, look at how people's lifespans have been extended, and a big part of it has been infection control. It's all the basics. So that I think that this is a phenomenal project. I also wanted to mention on scaling. I put a talk about teaching using XR to teach surgery in developing economies. Dr. Dondra from the NHS has been doing this for 6 years. He's got 50 applications of 360 video and applications, and he's been managing it. So it's good video to watch. He's an interesting guy, and it's all about scaling, that which is a challenge for them, but they're managing. I'd like to thank Veronica for moderating. Thank you very much. And then Erica, Vanelli, Michelle, and Andrea, thank you. It's great having the people doing the work, answering the questions that are specific. This video will be up on our website within a week, so we'll get that out. And thank you to our audience for joining us. This is, it's important to continue to tell the story of the XR innovator. And this is such a great example of situational awareness training. It's great engineering, great concepts, great clinical concepts. So thank you. And we'll see you next time. We'll start again in September. We've got a couple of interesting talks in the works that I'm sure you'll enjoy. So that's it. And thank you, folks.
Thank you all.
Thank you.
Bye,
Thank
everyone.
you.
Thanks.
Hi, thank you for having us.
Pleasure.